So I was just writing down some stuff, thinking about introducing this final session. We've got 4 presentations, 2 of which are topic-based, themes of what NCPOD's done in the past, and then 2 presentations sort of to draw things together and put this into a wider context. And I was writing a couple of words down during the presentations earlier in the day, just thinking about the things that are coming across to me about, if you like, the themes of the day. And the first word I wrote down was stories. And stories on several levels. So we tell stories in our reports. We provide vignettes that people have highlighted already today and illustrated how important the real life clinical cases are to bring home the message. The whole report is a story, and we always say that we know when we start to produce a report that we know what the messages are likely to be, because that's why we're producing a report. And then everyone who's presented today has told their own story, telling us about their improvement work and some amazing stuff that's out there. Second thing I wrote down was complexity. And people using a stepped approach, using care bundles, individual projects with all the challenges involved, and there's no doubt that improving quality always takes energy, overcoming the complexity in the system. I wrote down, because in the first session a couple of people used the words structure and process, and that reminded me of the Donabadian model of healthcare quality. I think it was 1966. He just describes it's the structures and the processes that deliver the outcomes. And actually then back to care bundles as a structure to put things into. We heard a bit about that earlier today, at the individual projects. And then the final word I wrote down was collaboration, because there was so much about people working together. And this final session was titled Working Together. So I just wanted to focus on the strap line, which is improving the quality of healthcare. We changed the strap line for NCPOD to that when we took over the child health programme, because we used to have a strap line that was improving the quality of medical and surgical care. And that clearly changed when we took over the medical reviews in 2003. But the reports are there to have an impact on quality, and we've heard so much already about the things that stem from them. And I was thinking about the things that actually have an influence on quality in the system, where we are a piece of that system. And I think it's always important to remember we're only one small piece of that big jigsaw. And again, the jigsaw that Donald used when he was describing quality, I thought was chimed with me. We always use national and specialty guidance when we're designing studies, so we ask questions to see if people are following guidance. But then we've heard already about how the impact of our reports is to help people develop new guidance and take things forward. I've mentioned care bundles again on this slide because I think they're a good tool to use in QI projects. And finally, what we've not really talked about is our own QI methodology or QI tools and resources that we put on the NCPOD website. So I thought it was worth just mentioning that for every report we produce a toolkit. The toolkit, a spreadsheet, you populate the spreadsheet, it'll produce one of these radar charts for you, giving an immediate signal about how well you're covering the recommendations. We've already heard about the trauma report, and I won't talk any more about that, other than to say massive change across the system. We heard about the lives saved and the impact there, and I put up here 2013 it took until there was a service specification or standard that was in place for trauma services. We heard a bit about the tracheostomy study in terms of a local QI project. Actually linking that with national work, the Intensive Care Society tracheostomy guidance was published on the same day as the NCPOD report. Not a coincidence, of course, we worked with the Intensive Care Society to make sure that happened. We've also talked already about Clinical Guideline 50, which encouraged the use of early warning scoring. That stemmed from the 2005 report. The 2007 report was the first place that it was suggested that there should be a maximum time to consultant review, suggested as 12 hours in that report. Actually now that's been adapted both in the College of Physicians Acute Care Toolkit and in the KIO standards to be 14 hours. We haven't mentioned some of the other national guidance that stemmed from previous reports. Some of the key guidance for managing cancer patients over most of the last decade was clearly influenced by the death following cancer treatment study. We've had an impact on specialist societies. This is just one of them. The National Vascular Database was adapted to ask the key questions that we put into our recommendations in the lower limb amputation report. And back to care bundles, in the alcohol report, we came up with recommendations that then influenced the British Society of Gastroenterology and Basel to form their care bundle for decompensated liver disease. So I'm not going to say much more other than to say there's two stories now about the impact of other reports. We're going to hear about, we've already heard about a local QI project about acute kidney injury, but we're now going to hear a bit more detail about some of the national work that was taken forward following this absolutely key study. And we're then going to hear about the non-invasive ventilation study, which was a study established because of questions raised by a national audit, where the national audit was showing worse results. We needed to understand that, and then work has been taken forward since to try and start improving quality of services for these patients. So I'm going to stop there.